I call upon our professor, Dr. A Ramachandran, who needs no introduction, but still for the sake of the youngsters here, he was the one who initiated and ignited the academic interest by all of us who are conducting this program by his effective lectures. Rather than talking about theory, which is always available in the books, he gave his real experiences, and we read only things what is happening in other countries, but he was the first few, like our Professor says here, to say what happens and what will fit to our country, and giving information on Indian data. And any conference in those days, if we see his name, the hall will be crowded, fully crowded, to know the information what he says. I think now, after this session, you all will agree with me. Thank you. Over to sir.
Yeah, thank you. Thank you, respected chairpersons, and thank you, Vijayakumar. I congratulate Vijayakumar for such a fantastic, excellent organization of this meeting. So many people. We have so many meetings nowadays, and getting audience is more difficult than getting speakers, isn't it? Okay, this is an insulin symposium, and Kumar has actually given you a good idea about basal insulins, and I'm going to talk to you about the new basal insulin, Glargine U300. There's a lot of confusion among doctors, physicians, and GPs because we are getting newer and newer drugs almost every 6 months. We have new oral agents coming, new types of insulin coming, new types of mixtures coming, and this is one of the new ones which has come. So probably I just explained to you exactly what is Glargine U300 and why it is superior to the basal insulin which have been already there in the market. These are my disclosures, and well, for the first question, of course, a little more fundamental, you can go, why do you want to use insulin for type 2 diabetes? I have lots of patients coming to me and telling, I've been put on insulin and I think I don't need insulin. Can you stop insulin for me, because I know I have diabetes which is can be controlled with tablets. So why should you use insulin at all? The first thing is, the only drug which can give predictable response in hyperglycemia is insulin. And also you know that many patients with type 2 diabetes have very low beta cells. You must know that in the pathogenesis of type 2 diabetes, without beta cell dysfunction or without beta cell failure, you will never get type 2 diabetes, however amount of insulin resistance you have. Although when you read the textbook, you'll read that the pathophysiology of type 2 diabetes, you have insulin resistance and beta cell defect. But the most important thing is beta cell defect. And insulin has been used for more than 100 years. And we have some data to show that those agents which will improve insulin secretion have better control, especially in the Asian population. And large number of, if you take type 2 diabetes mostly in the West, you have 90% of them absolutely overweight and obese, but not that case in our situation. So we have a lot of non-obese patients who have severe beta cell deficiency coming for the first time presenting with type 2 diabetes, and they will definitely require insulin for better treatment of diabetes. And the other thing is that I told you predictable response, the HbA1c reduction. Of course, the HbA1c reduction for any agent depends upon the baseline HbA1c. But having said that, there is always some limitations what can be achieved with the oral agents available today. But that is not so with insulin. Any MR, unlimited, that's the percentage you give. The HbA1c reduction with insulin is unlimited. So there is no upper boundary for that. So therefore, insulin is a good molecule, can be used. The next question is, of course, just now Kumar talked to you about basal insulin. Why do you need basal insulin? Why do you want it? The only oral agent which actually can reduce the fasting plasma glucose is metformin. So therefore, the other agent which can reduce the fasting blood glucose is basal insulin. Basal insulin works overnight, and it can actually suppress hepatic glucose production in order to reduce your fasting plasma glucose. And then you must know that if you control the fasting, you know the saying, fix the fasting first. Fasting hyperglycemia contributes to the overall diurnal hyperglycemia, so that if you reduce the fasting, you can actually expect a carryover effect in order to get a better glycemic regulation. The last one is something which I wrote myself, and that's called basal insulin can probably change the natural history of diabetes. You know that we talk about type 2 diabetes is a progressive disorder, As years go by, you start with half a tablet, 1 tablet, 2 tablets, after the 3 tablets, 4 tablets, and then finally insulin. That's the way you write the family. Because according to the natural history of type 2 diabetes, based on randomized controlled trials. So this is the slide which I told you about. If you fix the fasting, you actually better control. Type 2 diabetes is a progressive disorder based on the randomized controlled trials. This is what you will be reading in any of the latest textbooks. This is despite whatever be the strategy of treatment that you use, it will be a progressive disorder. And mainly it came from the UKPDS done in the 70s. And according to them, there's a continuous progressive decline of the beta cell function. This is the UKPDS, and this is the slide which has been probably projected a million times, showing that whether you use insulin, chlorpropamide, glibenclamide, or conventional, because these are the drugs which are used in 70s, you have the same natural history of the tick mark, which actually shows there's a progressive decline in the HbA1c. Now, in a later study called the ADOPT trial also showed the same thing. This is glyburide, again glibenclamide, metformin, rosiglitazone. Even there you found after the initial good glycemic regulation, there is a further deterioration of it. And this is actually due to the beta cell dysfunction occurring progressively. Now, the only trial which is done lately, the origin trial which Dr. Kumar actually mentioned, is the one which actually shown the other way, where we started with an HbA1c of 6.4 and actually ended up at 6.2 in the intervention group. So therefore, it is not true to say that in the natural history of type 2 diabetes, it's a progressive disorder. It is because we are not probably treating it properly, because if you probably treat it intensively from the beginning, you can actually negate that idea that it's a progressive disorder. This is origin trial where the patients were given Glargine insulin in the beginning itself, very early in the stage of diabetes, not newly detected, but these people already had cardiovascular risk factors. But the recruitment criteria, inclusion criteria was the patient should be only on a single oral hypoglycemic agent. So therefore, they were recruited at a very early stage in the natural history of type 2 diabetes, and there we could find that there was no deterioration up to 7 years. Now, it is possible, now this has happened only because the basal insulin analog was got available in the 70s. Now, it's probably possible that this can be replicated today by using the new agents which we have, because we did not have the incretin-based therapy and the SGLT2 inhibitors, which are very good drugs and do not produce hypoglycemia at all. So therefore, maybe this is possible, and there is some data coming on from some of this trial to show that is called better beta cell preservation with incretin-based therapy as well as the SGLT2 inhibitors, not the old insulin secretagogues like sulfonylurea. Okay, so having said that, the ideal basal insulin analog, which should be more than 24 hours, should be peakless, and should be minimum inter-intra individual variability. This should normalize the fasting plasma glucose. That's a very good term. It should normalize the fasting plasma glucose. You don't say control fasting plasma glucose. That's a term Hetzel Justin used when he started the origin trial. Kumar showed you the INSIGHT trial, which was also done by Hetzel. It should be weight neutral. It's not that it should be weight neutral. It has been shown that if you use basal insulin analogs, you can control fasting plasma glucose without making a gain in weight. And that's because the action is suppressing the hepatic glucose production and not as much as improving insulin entry into the muscles. When you want to use insulin to actually improve peripheral utilization of glucose, you need to use higher doses of insulin, and then you have a weight gain problem. That doesn't happen when you use basal insulin analogs. Of course, minimum hypoglycemia, of course, cardiovascular safety and non-mitogenic, mimic physiological release of insulin, and that has been already shown with Glargine. Of course, if you're practicing today, you have the first the NPH long-acting, then the Glargine came, which was a revolutionary molecule in the history of insulin. 2002, it was actually introduced, and Glargine revolutionized. And that is why after Glargine was introduced, which actually minimized hypoglycemic episodes, basal insulin became one of the second intervention or strategy in the guidelines by the ADA. So it actually even changed the guideline. The origin trial changed even the guideline for treating type 2 diabetes. So you have the Glargine, which is working for 24 hours, and Detamar. Then the latest two ones are the Degludec, which is called Tresiba from Novo Nordisk, and the Glargine 300, about which I'm talking about, which is the Sanofi insulin, which are both are very flat ones. So that is the journey of Glargine 300. This is called Toujeo. Those people are not even know what is Toujeo. Toujeo is actually Glargine 300. 1 cc contains 300 units, and it's a disposable insulin, and it's one cartridge, one disposable pen will contain 450 units, not the usual 300 compared to the usual ones which are available. And therefore, the volume of insulin will be further down, 1/3. And less injection force is required, and of course, there's a cost advantage. The reason why it is becoming flat, all these new insulins is, please understand, it is not the difference in the molecule of insulin. It is only in the dynamics of its absorption from the subcutaneous tissue. When you inject, the lower down, it shows the Glargine 100, where the surface area of the depot is much larger. When the surface area is larger, there is a faster absorption of insulin from the subcutaneous tissue. When you put the depot into a smaller one, smaller bolus, where the surface area is much smaller, as you see on the top, you see that the absorption is much lower. When the absorption is lower, then you have a flat insulin levels in the blood, and that makes it a long-acting insulin analog, reduces the risk of hypoglycemia without any fluctuations in the insulin levels in the blood as well as, because when you inject even an NPH, there is a spike of insulin going out into the pharmacological levels in the blood, and that is why you get the risk of hypoglycemia. So the risk of hypoglycemia drastically comes down. So it's a more compact and smaller depot, and more gradual and slower release of insulin from the surface of the depot. More constant and prolonged glucose lowering profile, maintaining blood glucose control beyond 24 hours. And therefore, there will be, within the day, there will be much less fluctuations. That just shows you, of course, the benchmark insulin has been Glargine 100, but the introduction of IDEC, which is the Degludec insulin by Novo Nordisk, that became the benchmark. So what is shown here is the variability comparing U300, which is Toujeo insulin, with IDEC, which is the Novo Nordisk Tresiba, showing that is almost comparable. In fact, Glargine U300 is almost flatter than the IDEC. The other point is, you must understand that Toujeo or Glargine U300 is not a new molecule, which is very reassuring. You may remember that we had some problems with insulin analogs having mitogenic effect, and there are papers in Diabetology published about 10 years ago, 3 papers on whether cancer can be increased by increasing insulin, because insulin is an anabolic hormone and it can be mitogenic. But now we know, one of the first, in fact, the origin trial after 7 years, which actually also looked at any cancer incident, showed there was no increased risk of cancer. So it's a known molecule, and it is also cardiovascular safe. So one advantage of Glargine 300 is that it's a molecule which has been used for several years and is a pretty safe agent. I'm going to give you just this is a randomized control trial where Sanofi was bold enough to do a head-to-head comparison of Glargine 300 Toujeo with insulin Degludec Tresiba, which is Novo Nordisk molecule. And that is the design of the study, and what you took was patients for more than 18 years, which was BMI 25-35, no prior insulin use. So you take type 2 diabetes with only on oral hypoglycemic agents, or also on GLP-1 analogs, they were not excluded. And you find it's a non-inferiority. So what you're going to checking is actually, there are 3 things you check. You check for what is called efficacy, and efficacy can be checked by looking at fasting plasma glucose, postprandial plasma glucose, HbA1c, and the daytime variability, the M value. We can also check for hypoglycemia. These are important things. And of course, there's an effectiveness. So it's efficacy we are checking, and hypoglycemia. As you can see, the efficacy is absolutely comparable. And you can see on the right-hand side, you have a very exactly identical reduction in HbA1c both with IDUC and Glargine 300. This is a comparable fasting plasma glucose and SMPG reduction with both these molecules. So it's pretty comparable. This is showing similar 8-point SMPG when you do it 8 times in a day. And on the right hand side, you have the variability, which is pretty similar. So there's this is absolutely non-inferiority. So the U300, the old Glargine insulin put into U300 concentrated form behaves exactly almost like IDUC as far as efficacy of glycemic control is concerned, which is pretty education. This shows you hypoglycemia, and this is a takeaway because that's the price that you get. You found during the titration, unfortunately, there was no difference in hypoglycemia during the maintenance period, which is in the bottom. That is it. But during the titration time, it was found that actually Glargine 300 behaved better. It reduced the risk of hypoglycemia, and as you can see on the incidence rate and the even rates on the right hand side. So therefore, on the left, if the forest plot showing on to the left side, it favors Glargine U300. This is showing you the nocturnal hypoglycemia, which also showed definitely an improvement in the hypoglycemic episodes. Of course, real-world evidence also show that changing over from Glargine 100 to U300 or to IDUC, there is similar glycemic effects. So to summarize, BRIGHT was the first direct comparison of Glargine 300 versus IDUC 300, Toujeo versus Toshiba. Similar glycemic control, and there was no difference in the hypoglycemia in the full study, but there was a decreased, statistically significant reduction in hypoglycemia during the titration period with Glargine U300. So I think I finished here. Thank you.